Another great point, Leslie. And I don't remember if microtransitions are addressed in the CPG or not, but that would be a good thing to address in the resources that go along with this as well.
Hey, thank you. I know Jenny was on. Jenny Albertson, you want to go next?
Sure, absolutely. I have just one very sort of brief couple of slide notifications to get through with you. If I could just share really quick.
Yeah, I'll make you a co-host. Give me 1 second.
Thank you, Ian.
Sure. Gotta find your name. Do. There you are. All right, so there, you should be able to share.
Okay. I don't have anything majorly from the association's perspective, but I do want you to be aware of a couple of buzzing issues that are out there that impact medical directors. The first was actually triggered by one of your members for me to look into it, but it was actually already very much part of the zeitgeist. Apparently, there is a new focus for a lot of for-profit companies, at least, on improving Medicare reimbursement by offering an extended respiratory therapy program. This has gained a lot of attention from the Office of Inspector General because it increases the Medicare spend, which of course automatically makes them high on the audit list. So respiratory therapy is permissible as a billable service under CMS guidelines and Medicare Part A and some Part B. And so there are right and wrong ways to do it. And so we've encountered some of our members needing to alter their approaches so that they are more in line with documentation requirements. Others have undergone audits and found that they had some areas that weren't very tight in that arena. But the bottom line from your perspective is that if you want some detail, CMS has a very good article explaining examples of proper use, examples of improper documentation, and so forth. It's very clear. And they primarily are driving at ensuring you have given an appropriate order, the treatment is specified, the documentation correlates directly back to that specified treatment and order, and then it's being provided by someone qualified specifically to provide that form of respiratory therapy. So in some cases, it's an RN. In others, it has to be an actual licensed RT, and it depends on the billing codes. So that CMS article is really your Bible when it comes to RT and making sure you are documenting appropriately for your orders. So that's the first piece. The second piece is this one keeps coming up, and I know I have touched on it with you all before, but there was an executive order signed in December that altered how we look at marijuana. In Colorado, we of course had our own pre-existing law that permitted both medical and recreational use. The executive order specifically applies to medical use under state laws. So it's meant to liberalize and make room for what we already have in place. It reschedules marijuana as a Schedule 3, but it is only for the FDA approved drugs that are related to marijuana. And so that would include only the 4 that are listed and linked below. Epidiolex, Marinol, Syndros, and Kesamet. So they have specific FDA-approved uses. You all, of course, are far more versed in this than I am, but under Colorado law, there are diagnostic criteria that slate the patient's medical use under either a doctor of medicine or osteopathy versus a wide range of medical conditions that allow dentists, PAs, podiatrists, optometrists to become essentially prescribers or recommenders is what it is considered for use. And that's the more psychological, a neurological category set. And also a permission to replace opioid prescriptions with marijuana use under those categories. So I suppose it's worthwhile for you to have conversations with your QAPI teams for how this is codified, how it is communicated at admission, whether your long-term care pharmacy will be willing to administer a Schedule 3, one of the 4 drugs that are allowable, versus how you're going to treat it if the person has a medical marijuana card and chooses to acquire their own medical marijuana products and expects to use them much like they would a supplement. Under our regulatory guidance, we really have confined ability to allow someone to bring in any kind of medication or supplement. It has to come through our long-term care pharmacies. We have to contain and have chain of custody, etc. So if you haven't had these conversations, I'm just encouraging you to do so. And if you need more information, please reach out to me. I'm here as a resource. Thank you.
Thank you. It was very helpful. Chad, I think I saw that you were on now.
Yes.
Would you like to share your updates with us?
You bet. You bet. I also wanted to weigh in a little bit on the marijuana conversation, and that is something that we're going to have to discuss further in our office because it is not federally legal. And so the use of that, we may have to get really creative in how residents are able to benefit from those substances in that manner. So I think there'll be more to come from us, but it is a conversation we need to have. We just had the nursing home roundtable, and if some of you were able to attend, you can attest to, first off, my struggles with technology. But, you know, what we've really done is I want to open up kind of the format with our discussion. And I want to bring some things together. I mean, we can go through regulations. We can all read the regulations, you know, and one of the things that we talked about that we find extremely valuable moving forward is that we gain some consensus between the communities and its leadership and nursing facilities surveyors and the leadership here, and gaining some consistency in how we're viewing particularly those regulations that, hey, they're all in black and white. Again, we can read them, but what do they mean? What is the intent of that regulation? And when we go and we do our investigations, we really need help understanding why. Why was care provided in this particular way? Because I think that the more that we can understand why, the better opportunity we have to have conversations as opposed to going straight to a citation. And we're going to rely on facilities to help us with that understanding. I know that when we start talking about more significant outcomes and findings, we've asked our surveyors to reach out to the medical director of the facility and have that conversation as well. I think there are things in terms of the medical, I hate to create silos, I hate to turn people into silos, but you know, that medical part of their lives. And you know, we're not doctors, and nor do we would ever pretend to be. But getting that understanding from you as medical directors and your perspective on, you know, conditions, needs, and the care and services that people are being provided, I think those conversations will be very valuable as we seek to understand and you know, wrap an understanding, of course, around the intent of care being provided in a particular way. Today we talked about bed rails, and it wasn't just about bed rails. We talked about assistive devices, and I really believe that, you know, while we have some companies out there, some communities out there that have looked at assistive devices as a whole as being a restraint, we also need to consider that not only are they not restraints, they're helping the person to be independent. They are an aid, and you know, people are benefiting from it, as opposed to a situation where it is restricting or prohibiting somebody in a particular manner. So, I would ask that everybody have those conversations in their communities, because
Could you get
I
my
believe
Yeah,
there
you should.
is a place
sent
for
you a
these
couple.
things.
Where the bean bags are for
And
cleaning?
if you're
Yeah, I can
not,
find those. Will you carry?
if you're not going to use them, then we also have to then look at, if you remove those assistive devices, what are you doing instead? Because the need is still there. And we would look to see how you are meeting that particular need. We talked through water temperatures a little bit, and I know that can be controversial. And the thing that I would ask is that we approach every situation assuming the greatest risk, and that if we do something different in terms of the scale that's provided by CMS in the state operations manual, particularly around showers, shower temperatures it notes that shower temperatures 100 degrees is a safe shower temperature. And I know that there are many residents who believe that's too cool to receive a shower. So I'm suggesting that if we do something different, we use a great deal of caution, and we provide that same system. We use the same system to evaluate, to care plan, to train, to make sure that our staff are providing the supervision that somebody might need, and then to reevaluate, because what we believe to be true, in a certain period of time may change. And then we don't want to be in a situation where, unfortunately, high water temperatures and actual serious outcomes will lead to findings of immediate jeopardy. So I'm just saying, if there is something you want to do in terms of resident choice and the whole resident directed care, that we proceed very cautiously, and that we rely on a very well-defined system of determining that people can be safe if should those the water temperatures exceed what is typically recognized. So, hey, I just wanted to provide a few updates from the meeting that we had previously. That's really kind of what I have for you today. If there are no questions, I just want to say thank you, and good to be here.
Thank you, Chad. I think you're on now. Did you want to drive our last section here about AI and whatnot?
I would love to. Thank you. Hi, everyone. This is Sing Pellet, president of PALTmed-Colorado, at least for another week. And I'm sorry I was late today, so great job moderating, Leia. Our next two speakers are going to talk about AI, particularly how they relate and intersect with our patient population. If you were at our annual conference, you would have seen David Ginsberg. He is an expert on health information technology and compliance, and I'll let him do a little more introducing of himself. But before we get to David, I've asked my colleague, Dr. Derek Sebade, nurse practitioner, who works with Optum in Arizona, and he and I were recently talking, and he shared a story that I thought, this is worth sharing with everyone. Just tell us your story, Derek, and we'd love to hear just how AI is just everywhere. It affects all of us, and it has real impacts. Welcome.
All right. Thanks for having me. Thanks for obviously allowing me to provide a brief view of a recent AI encounter with my mom, a medical AI encounter. So briefly, she's a 92-year-old female. She's functionally and cognitively intact, but declining, obviously, because of her age. She's actually pretty astute on the computer and her iPhone, and if nothing else, she probably could be a case study on elderly patients who are tech savvy or tech literate. This is not a case presentation, but I just want to provide a brief synopsis, and then I'll get into what happened. So she has a really long history of hypertension that has escalated quite dramatically over the last 5 years. She's followed very closely by a PCP, cardiology, and nephrologist who specializes in hypertension over the last 5 years. She's established a well-functioning system with Provident Healthcare in Orange County. Her physicians do actually communicate with each other. I personally read their clinical notes on the portal where they mentioned speaking to one another about her hypertension. She's also followed by a specialty hypertension clinic at UCI Medical Center. She's been trialed on numerous combinations of medications, as you can imagine at this point, and has been trialed on literally every drug class and combinations of drug classes, and continues to have poor control. So her most recent addition of medication was hydrochlorothiazide, which was added to her longstanding Darby and recent start of Catapress, which has now been bumped all the way to the 0.3 patch. She's had pretty good control. Good control for her is 150/90 with fluctuations, obviously. And she decided on her own, this was just a few weeks ago, it's probably about 4 weeks ago now. She decided on her own to put her medical history and medications into AI. So she did that, and A advised her to stop her hydrochlorothiazide and start losartan, which she's previously been trialed on multiple times with no benefit. So without consulting my sister or I or her physicians, she decided to stop the hydrochlorothiazide because, and this is her quote, AI is wonderful and so smart in figuring things out. So AI advised that she had the losartan, like I said, and stopped the hydrochlorothiazide. But interestingly, she's on a Darby already. So that combination is obviously contraindicated. Fortunately, she did not have any leftover losartan on hand. So she stopped the hydrochlorothiazide because of what her AI told her. 3 days later, she was in the hospital for a BP of 220/140. Fortunately, the rest of her workup, including CT, the head was negative for any acute cerebrovascular findings. So kind of a lesson for me on this, while I completely agree that AI certainly can provide considerable compilation of data, including recommendations for clinicians, differential diagnoses, potential medications, contraindications, useful diagnostics. Its use by patients or family members can lead to false outcomes or false expectations. So that's my brief presentation of an AI situation with my mom.
Appreciate that. Thank you. And thank your mom for letting you share that story.
Yep.
So David, welcome to our meeting, and we would love to hear what you have to say about AI.
Well, I think what a great preamble. Let me see if I can share my slides, and you should be able to see them now.
Yeah, we can see them.
Perfect.
No. Now we're
Perfect.
looking at the notes view, though, not the slides.
Okay, let's try to get out of that and go to a different format. But actually, I don't want to waste time trying to get out of it because I think I got stuck in it. So, anyways, that was a very interesting and all too common occurrence that we are seeing with regards to AI, both between tech savvy and non-tech savvy patients as well as individuals. My world, focusing on compliance in healthcare, we are really worried about the proliferation of AI to provide guidance in the compliance area or administrative areas. Obviously, in your world, it's more around the clinical concerns, but from the administrative area, we now have come across several of our longstanding clients who we are their HIPAA compliance officer who have taken on themselves to use AI to compare contracts, business associate agreements, and provide informed opinions without either legal or, in our case, consultative support to help them understand what really should be understood with regards to the nuances of an agreement and or get the background. And that seems to be the issue. The issues are usually the information that isn't fed into AI or that AI cannot glean is where we get ourselves into trouble because it can't make a really informed decision. So today I wanted to talk a little bit more about the legal issues. Rebecca had asked that we focus on that for today and then see if we have enough time to explore additional use cases related to AI. This was a slide we had at the annual conference, but I think it's pretty important to reiterate. data information is the core of an AI system. They're consuming tremendous amounts of data within their large language models, but one incorrect data point can then create or result in numerous residual or derivative decisions being made because of that one wrong data point. And interestingly enough, while there's a lot of research and papers being written on how AI is creating its own intelligence, I don't think it has yet. I don't think it's really been able to understand nuances as well as context. There's a lot of research and a lot of information about context that AI can now bring context to the situation. But in the case that we just heard about, there was no understanding. AI just was given information, prompted and responded in a very binary fashion, looking at data without any context of understanding the entire longitudinal clinical information related to the speaker's mother and her residency in the facility or independent residency and all the other components that go along with proper caregiving. So this is an issue, but it's also unavoidable because the fact is that we cannot stop the AI train, even if we wanted to. At this point, it has become so ubiquitous. The general challenge is with any AI engine is how well has that engine been designed? Was AI itself used to create the engine itself? So we are now beginning to see software being developed by AI. It saves a lot of human engineering, writing code, and things of that nature. But if AI itself is generating its own language and doing a lot of its own learning, which it's supposed to, but nobody is truly curating that, proctoring it, there will be issues with regards to bias. Recently, we've begun to see a lot more discussion in the industry, and also, I would say, on a general compliance area with regards to inherent bias built into AI. Bias from respect to racial bias, a gender inequality bias, again, because of the data that's been fed in. So if you have a very limited data set, and we all know this, obviously, from learning models that we've grown up with and studied in college and school, that if you have a very limited amount of information and you're getting biased information, then you will live in a biased environment and propagate that. So the AI tools and systems that are used need to always be validated from the perspective of their sensitivity level. How sensitive are they to data changes, and do they use that to mature the model? The diversity and accuracy of the model, and to what degree does the model's own hallucination end up generating new AI learning that is based upon faulty understanding? We talked a bit about this at the annual meeting, not enough. So I'm going to speak more about patient consents today in terms of the legal challenges next. And then the data security challenges have not gone away. There is a new threat on the horizon, and all of us need to be aware of it. We are all aware of ransomware, and hopefully everybody here not only using systems that are provided to you by your employer, but using your own personal electronics, etc., are very aware of phishing attempts and ransomware and the concerns about having malware installed in your system. There is now a very powerful agentic AI tool that is out there that could be licensed by what we in the industry call the cyber threat actors. The cyber threat actors typically around the world are not inventing new technology. They're using essentially the equivalent of open source code and programming that has already been developed or available in the dark web to do their own cyber attacks. But now there is an agentic AI model that is capable on its own of going out and doing an AI-based cybersecurity scam. Typically, we would see that around some sort of phishing attempt to, or text, we call that smishing attempt, to try to get information and then use that to gain a credential into a system, get into a system, and then typically the AI agent will know enough to look for usernames, passwords, what we call credentials, and then they will use that, the agentic system will use that with a few human prompts to try to escalate an account, create a new account with new credentials, and then use that to do long-term reconnaissance of a particular company. We just recently worked with one company that provides services to healthcare vendors that had such a ransomware attack. And when the threat actor was asked to provide proof that they actually had taken data, it was obvious that the proof that they provided this was written by AI. It was fascinating to study. It was a multi-page document of approximately 120 files they had ransomed and locked from the network of this organization. And their AI agent went through and did a very, very provocative analysis of how these files contain patient information and why, and what they were related to, very accurate. They were describing revenue cycle billing data that they'd found, describing patient data, went as deep as to describe what kind of protected health information and why those data elements were PHI. And the only problem was everything they said was entirely wrong. But it was scary as hell to the organization that received this. Once we began to look at it and look at the files, we recognized that it had made a number of assumptions because of the organization that the data was actually patient data, when indeed it was actually, fortunately for this organization, marketing data and a lot of graphic files and a lot of information that just said patient this or patient that in the title. So it drove home for us, though, the fact that from an AI use perspective and ubiquity, now the threat actors themselves are using AI to, at no human cost of their own, they're not hiring people. They're able to just go in, get into your system, and then they can create very, very threatening and demanding issues. And in this case, they were demanding hundreds of thousands of dollars to be paid. But it took the organization thousands of dollars to figure this out and be able to figure out, well, I guess this isn't really an extortion. No true data was exfiltrated. Here's what we need to do. But that speaks to the fact that the models themselves are still immature. This will change. I mean, obviously, we know that they're going to get smarter over and over time and be able to themselves tighten up their own sensitivity levels. But let's pivot. Let's actually segue from this more into the legal issues. This is a very, very interesting recent class action lawsuit. For those of you that are not Northern Californians, you may not be familiar with Sutter Health. Sutter Health is the 800-pound gorilla in the Northern California in terms of healthcare, owns and operates multiple hospitals and medical practices and clinics, very, very big, been around a long time, using the Epic platform throughout their environment. There was a recent class action lawsuit challenging the use of AI, in this case, medical scribes, to scribe the notes of a patient treatment session or a patient encounter without the appropriate, or what they call meaningful, informed consent from patients to record and transmit their medical conversations. Fascinating, because nobody can, you just can't walk up and say, I'm going to launch a class action lawsuit. It takes a lot of legal muscle, and it takes getting that class action lawsuit essentially ultimately approved by a judge for it to go forward into the litigation process. This is the first one I'm aware of. I think this will be followed by many other such lawsuits about the use of AI where an individual, a patient, in our cases, doesn't believe they've been given the appropriate ability to know that this is being done. Clearly, we do have an obligation to tell patients anyways if we're recording things about them. There are some states that actually have specific law that says you have to ask the patient to get their consent to any kind of recording. HIPAA is a little bit ambiguous about this, except that if you've given general notice to the patient that you're recording their information, it may be sufficient. This class action lawsuit, however, helps us think about where the risks might now be cropping up. There are some of you, obviously, I know today that are in more of a private geriatric practice. There are some of you that work for the big organizations, corporations, but you may not actually change the regulations or be able to change your internal policies, but it's important to be aware of that. And it's interesting to see what laws are cropping up or being passed at state levels to strengthen individual rights in the face of medical scribes or the use of AI. Utah's statute mandating that healthcare professionals prominently disclose to a patient whenever AI is being utilized to ask them questions. So this is interesting. I recently went through the process of applying for a lease on a second residence that we have, and I thought I would be talking to an individual representing the building, and I ended up talking to a very pleasant AI chatbot. Her name is Amy. She didn't tell me her last name, but her name's Amy. And she could have been of any ethnicity. We didn't know. So there was no bias when I was speaking to her. It was just Amy. She was extremely efficient in responding to all my questions and had been very, very well trained. It was an interesting experience. Clearly, it worked for me in that non-clinical interaction. But in this case, Utah's regulation, I think, is smart in as much as if you're going to have an interaction where there's questioning and answers and response, there should be some notice given or to the patient so they're aware of that, who they're talking to. They're not actually talking to a provider. And I think that's really important. I don't know if this would have made any difference because in the case we just learned about, it was the patient themselves initiating the AI chatbot, but I would wonder if at the end of all that information, AI said anything like, this is an AI generated clinical guidance for you. We urge you to talk to your own primary care physician. I suspect it didn't say that. And maybe there will be laws down the road that will actually force that, because otherwise we're just going to follow it blindly. Colorado's law, which will apply to everybody today on the call, is an interesting one. They've created a new terminology, automated decision-making technologies, ADMT, that could be used to materially influence a consequential decision for certain covered domains, such as healthcare, insurance, education, etc. And there was a little proviso added to this SB 26-189 in basically the end of last year that said, if you're a HIPAA covered entity, which most everybody today on the call is, I would think everybody is, then you and your business associates are exempted from the developer requirements. So this was focused not just at people using it, providers, but also focused at the developers of the software. But if you're using an making employment related decision, then you have to provide people with information related to it. It then just said you can provide a general notice regarding how you'll use advanced technology, including covered MD. So there are some Colorado laws that would go far enough, I guess, to say we should be able to tell people that we are using AI. We should be concerned about our consents and so forth. I'll talk a little bit further about that later on and what kind of language we're getting to support that. Um, some experts are saying that you, in the end, don't have to worry too much about AI, that everything in a legal malpractice case will revert back to reasonable physician standard. And for those of you that have been involved in professional liability cases against yourself or participant, you know that that standard is used heavily. Did what you do, were the clinical decisions you made part of a reasonable physician standard standard of care in your area, and can you support that? But we are more worried today that those kinds of reasonable standards will be penetrated by a plaintiff's attorney who will try to find flaw with the AI model. And more importantly, what I'm concerned with is for those of you as licensed providers, not just say, well, was this the standard of care, but did you do the proper due diligence in reviewing the model to be sure that its decision making would be correct? Excuse me. And can you provide evidence that you actually used your clinical judgment skills to review what was provided to you and make a decision? So I just want to leave that for everybody to think about. If you're using an AI scribe and it's creating the note, how do you then document that you reviewed the note of the AI scribe and accepted it? And are you even doing that? Now, I don't see, Ian, we don't have like a poll, right? I'm sure we could have if I'd given you an advance warning, but it would be interesting to know how many of the scribes that folks are using, that what you're doing in terms of your actual medical record, be it in GeriMed and Epic, Point Click Care, wherever it might live, to say, oh, this was an AI generated note, but I reviewed it and it's correct. And by the way, there's a huge danger. As we get busier and we get more reliance on it, we're not really going to review it. We're going to be kind of our old normal lazy selves. And I shouldn't say it that way, it sounds shaming. More of our just, I'm busy, I'm just going to skim it. And we're all skimmers these days, so we'll skim it, but you'll miss something very critical. So some of what today is just challenging us with more questions that, being a good salesman will, maybe you'll invite me back to follow up and do another session. And I appreciate it because the compensation is so wonderful that you're paying me for these. So I really appreciate that. That's just tongue in cheek. Sorry, Leah. Okay, so this slide inadvertently got reiterated there. I'm going to take it back out. Let's jump into compliance. All right, so HIPAA privacy. Earlier, we talked about that class action lawsuit where the plaintiffs are saying they did not receive clear notice. Their conversations would be recorded by an AI platform, transmitted outside the clinical setting. And what does that mean? Well, most scribes that are used by a software may have come from yet another party and may be stored in a different cloud. So let's take a look at one may very well hypothetically say Point Click Care. Point Click Care has everything living on their primary cloud, but they may have licensed a third-party AI tool. That third-party AI tool, may in turn live at a different cloud. That cloud may be somewhere not in the US, for all we know. It may be in, God forbid, a communist country like Canada. Sorry, Leah. Tongue in cheek, I'm Canadian, so I can kind of say that, right? So basically, do we have the right controls there? So essentially, from a privacy perspective, we have to look not just at the platforms we're using, but if AI is embedded in them from a compliance perspective, what AI is being used and where does that data live and who are the stewards of that data? Definitely, I think the message I want to give today is your organizations, whether you're working for Optum or for a hospital or a nursing home or whatever, should consider that they may need to be updating their general patient consent forms. So typically we have, as you guys know, multiple forms. You're going to have the HIPAA notice of privacy practices that a patient will receive. That bland notice that is multi-page long that says, here's how I'm going to use your information for treatment payment and authorization, and here's where I need to get your treatment payment or healthcare operations, and here's where I need to get your authorization. And then you'll have typically a patient treatment consent. Well, if AI is going to be used, I'm contending now that the consent form has to evolve and be somewhat specific to the use of AI and how and where. And that means that consent form may need to evolve because you may start by saying all we're doing is using a ambient scribe, but then next year, point click care, Epic, GeriMed, whatever you're using, comes up with some new model that does something else. So you may need to think about incorporating that. The problem here, the caution is people don't read their consents, right? And especially worse when you have if you have those little electronic signature pads, right? You just sign, 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 and you never actually reading the document that was delivered to you. So it's going to be a fascinating legal decision or discussion, rather, not decision down the road, to the degree that we'll have patients signing and receiving many consents, but they'll come back later and say, I don't remember agreeing to that use of the AI. So again, I think one of the points I want to make is that I think our consents need to evolve, and definitely the other document that needs to evolve in your organizations are the notice of privacy practices. So if all of you are HIPAA compliant organizations, you'll typically have a notice of privacy practices. We are recommending that notice then have a new sentence in it that says we may use artificial intelligence for the purposes of our treatment, diagnosis, or payment or operations, etc., so that the patient is aware of it. Again, there's good and bad. The bad is that patients don't read it. The patients that do read it in your environment are going to be the curmudgeonly old retired attorney living at assisted living or living in a nursing facility that will want to spend a lot of time arguing with you about that, right? So think of me in about 2 years' time being the one that would be arguing with you about that. It won't be your rank and file patient. So when we add more in the consent, we add more in the notice, we're going to end up having patient interaction. That's not for you from a clinical perspective to worry about, but it will be an administrative burden if somebody's going to hand that form and then the patient's going to discuss that. From a compliance perspective, though, with regards to updating your consents and understanding more about the AI impact and the legal issue, we kind of come back to a common theme that we are also reinforcing and have been in the last 6 months, which is every organization, whether they be Optum, huge, or a small organization, should inventory and know when and where AI is being used. The problem is we won't know the personal use. And the personal use can get you in trouble. So you want to even ask that question. Are you using Claude? And if you are, what are you using it for? And we need to know if that person's in your employee and it's going to have any impact. If they're using it for their own personal use and it has nothing to do with you, they don't have to answer and they shouldn't. but if they're using it in any way, shape, or form to improve their work, and why shouldn't they? It's fabulous. I mean, a lot of people are just saying, hey, I got these three different lists of information. Um, I'll give it to Claude and let Claude make one list. And there's like these little time savers that it's able to do a fabulous job of. But we need to know about that in order to come up with a policy. Now, I'm not I'm not done, and I know I'm getting close to my time. But I think to the leadership team, this tells us we can probably have another meeting down the road and dig into it. What I want to leave the group with today, besides the legal stuff that we talked about, increasing or improving the utility, the specificity of the consents, is also not to deny AI in your organization or your own use. I think it's fine to embrace it, but just understand and put the right guardrails up in terms of using it. And what I leave here with is that from a clinician perspective, I've been spending a lot of time trying to think in a medical practice or in a long-term care practice, how is AI really going to help you? And it always comes down to where are the repetitive tasks that are done that can be time saved by having that automated and done by AI that have very little or low potential for data security issues, privacy issues. Those are things that might have great value. Or personally, and how much time do you spend getting ready for the day's visits? Now, everybody's got a slightly different model, but to what degree are you getting prompted to know the patients that you're seeing and what you want to be focusing on with those patients? There's one little analog I want to give to this that we have found from AI to be amazing. It has nothing to do with clinical care. It has to do with revenue cycle. One of the biggest reasons for having an accounts receivable in private practice, and it doesn't really affect as much here except for outpatient care in your practices, is a patient we think is eligible, but actually isn't eligible because their Medicare Advantage plan switched or their this happened or that happened or whatever. And a simple exercise of every day having a list of all patients coming in and their current eligibility status, we have seen able to drop the accounts receivable dramatically because your front desk is prompted to ask for up-to-date information. Slightly different in long-term care, obviously. But that is a good example of AI could do that automation and bring that information and provide it to a practice so you save somebody the effort of having to do it and you don't worry about somebody being sick or not there that day. You'll always have that. So I know I don't want to overstay my welcome. So I think, Leah, I'll stop right now. And if there's any questions, otherwise, I'll let you guys wrap up.
Thank you. That's so thought-provoking and but also very relevant. I think you hit on a lot of aspects that do come up in our day-to-day lives.
We had a good question sing in the chat. You want to read it out loud?
Yeah, I think when you were talking about making disclosures, David, I thought a lot of our clinicians will use things like open evidence and other data sources. And I think Claude might be one of those.
Yeah.
You can ask clinical questions and it'll give you some answers with some references. Do our patients have to know that we're doing that and using that into our clinical decision making?
I don't think you have to get that granular, Singh, because if you've used it and then you've evaluated that and you've been able to then take a derivative of it and use it to share, I think then that's part of your clinical judgment that you can rely on without disclosing. But I think that at some point, again, organizationally, if you're using AI to help you, it would fit in your HIPAA privacy or notice of privacy practices that you would say, and we are using AI. So generically, you're giving patients the awareness of that use.
Thanks for taking the time to answer that and to give us the presentation. That was a really great follow-up from our annual conference.
Thank you.
Now we're at the top of the hour, and so appreciate everyone who was able to join us today, and thank you for our moderators too. It is the time of the year when we are electing our board of director officers. And rather than having our candidates speak about themselves, although you're certainly welcome to, but I think Leah's the only one that's still left on the call. We are going to send out ballots to everyone who is a current member of PALTmed-Colorado. It'll have the biographies, as you can see on the screen, for each of our candidates. And we would love for you to vote them into office. The other announcement I wanted to make was that our first Thursday of the month journal club is canceled for this month because of the holiday, but we'll be back in August. And we're going to change the name of it. We're going to call it the PALTmed Learning Community and focus on clinical topics that are really important to all of our clinicians. The goal is to be able to award CME for people joining those sessions. And so we're going to move away from the name of Journal Club over to Learning Community, but we're still going to be learning. We're still going to be talking about journal articles and talking about evidence-based medicine. But watch for that, and we'll give you some more details to come. Anything else, Leah?
No, thank you so much.
No, thank you. Thank you. Have a good day, everyone.
Bye.
Thanks, Leah and Singh.
Good to see you.
26, but still go ahead and do
Thanks,
the
everyone.
40.
Thanks, everyone.